presentation today on Medicare for All. This is part of the Healthcare Durango organization, which is really not a corporation or anything, just a group of people who get together and really advocate for universal health care. And there's a lot of confusion about Medicare for All. So one of the things that we thought that we could do as a group is to talk about it, inform people about what it is, what it does, how it's different than what we have now. And of course, this particular presentation, we're going to talk about how much it might cost. That's not something we've done before, but there's a number of studies that have been done that talk about that now. And so we're going to go through it a little bit and say, is this going to be super expensive, or is it going to be cheaper than what we got now, or whatever. So just to warn you, today's presentation is being recorded. We have recently created a website, which is healthcaredurango.com. And so one of the things we want to do is put this presentation, or maybe certain sections of it, on the website so that people can see it. So that's something that's new. It doesn't have a lot of content yet, but we're working hard on getting more content on the website. And you can also email us at healthcaredurango@gmail.com. And my name is Gwen Unger. This sort of came out of the Indivisible Healthcare and Senior Issues Committee. So some of us have been involved in that for a couple of years now. And there's some people that have really been making good contributions, some of our key members to Healthcare Durango. I just listed their names here to give them some credit, because it's certainly not me doing all this work. And I think just to make this program flow smooth, we'd like you to wait until the end to ask questions. If I say something that you just don't understand, then by all means raise your hand and we'll try and clarify that right then. But in terms of general questions and follow-up, I think as we go through the program, you'll probably get questions answered, and then when we get to the end, if you've got other questions, we'd certainly be glad to entertain those. One of the things we want to talk about is how the heck did we get here? Why are we even talking about this? What's the problem that exists now that we would like to solve through some sort of universal health care? And of course, the first thing is many people still don't have health insurance. That's a big problem. Even after the Obamacare, ACA has put a lot of people onto insurance, there's still a lot of people that don't have health insurance. And of course, the United States is the only developed country that doesn't have universal health care. And we'll talk about exactly what universal health care means here in a minute. The third issue is our health care has become incredibly expensive. Anybody who's running a business and buying a plan for their employees, or anybody who's on the Obamacare exchange market trying to buy insurance, you know how expensive things have become. And unfortunately, healthcare costs continue to rise at a rapid rate, and really what I think is an unsustainable rate. So the uninsured rate for people of all ages in 2017, this was the latest information I had, was 8.8%. That's 28.5 million people who just flat out don't have any health insurance. Many more are underinsured. What do we mean by underinsured? It means that they have a policy, but they can't afford to use it. So they may have a $5,000, $6,000 deductible that they would have to pay if they had to go to a hospital. They would have to pay that before the insurance started kicking in. So there's a lot of people that can't afford that, even though they have a policy. There's also some very high co-payments in some cases where they have to pay a certain amount to go to the doctor. Prescription drug prices are getting higher and higher. So even though people have insurance, we say they're underinsured because they can't really afford to use it. And I've tried to put references to where I'm getting this information on the different slides. So I'm not just making this up. Universal health care, what does it mean? So universal health care is any system where everyone receives the medical care that they need, regardless of who they might be. And so medical care is typically available without regard to age, gender, religion, legal status, or ability to pay. But it's not one particular way of doing it. Universal health care is not a single system. It can be any type of system as long as it covers everybody. And again, as we said, every developed country except the United States offers universal health care to its residents. In 2018, we spent a total of $3.65 trillion on health care in this country. That's what everybody spent together on health care. $3.65 trillion. And I wrote that out just so you can kind of see how many zeros that really means. And we'll talk more about that later. But keep that number in mind. Last year we spent $3.65 trillion. So that's approximately $10,500 per person. If you take the $3.65 trillion divided by the population, you get $10,500 per person, which of course is then about $21,000 per couple, or $42,000 per family of four. So the average family of four in this country, somebody spent $42,000 on their medical care. Just to give you another idea of how big that $3.65 trillion is, on the left is healthcare spending, and on the right is defense spending, total defense spending, which was about $700 billion last year. So you can see that we spent about 5 times as much on healthcare as we did on defense spending. Just to give you an idea of how much money we're talking about. And we pay about twice as much per person for healthcare in this country as other developed countries. So I show you up here some numbers from different countries in 2017. We're typically a year or two back on our statistics. It takes the economists quite a while to get these numbers together. But in 2017, we spent $10,209 per person versus Germany, which was the next highest of the developed countries at $57.28. And then you can see France, Canada, and the United Kingdom all spent substantially less than half of what we spent per person. So we'll talk about this a little bit more as we go along, but I wanted to play a little bit of a video here. This is the hearing in front of the Rules Committee of the House of Representatives that happened a couple of months ago. And the person that's talking here is, I can't remember his name, but he's an economist, and he was one of the witnesses.
If we look through medical equipment, prescription drugs, physicians' payments, dentists, we pay twice as much as everyone else in the world. Now, will we get down to other levels? That's an open question. But there's no obvious reason we should be paying twice as much for our drugs, for our medical equipment as people in France and Germany. We don't pay our auto workers twice as much. We don't pay twice as much for cars. It's not clear why we should pay twice as much for health care.
And just to point something out, this lady right here is Pramila Jayapal. She's the one that wrote the Medicare for All bill in the House that was introduced this year. So since she was in the picture, I thought I'd point her out, because we'll mention her bill a little bit later. So we're spending this huge amount of money. The other thing that's happening is our medical costs are continuing to rise much faster than the general inflation rate. So what I did here was I took some data from PricewaterhouseCoopers and inflation.eu, and I just laid out from years 2007 to 2016, those 10 years. And you can see here in the middle, this is the medical inflation rate, and this is the overall inflation rate. So the inflation rate is how much more does it cost for something this year than it did last year, the exact same something. So if there's a 2% inflation rate, and I go buy a bottle of aspirin for $1 last year, it's going to cost me $1.02 this year if there's a 2% inflation rate. Okay? So you can see that in 2007, the medical inflation rate was 12%. While the overall inflation rate was 2.8%. And the next year it was 9.9 versus 4. You can see in 2009, because of the Great Recession, the medical inflation rate actually went negative. So things were slightly cheaper at the end of 2009 than they were at the beginning. And yet, the medical inflation rate was still 9.3%. And if you come down here to the very bottom, I compounded these interest rates, inflation rates. So over that 10-year period, medical inflation rate was 125%. So that means at the end of 2016, things cost more than twice as much as they did 10 years earlier in medical. And you can see that the overall inflation rate during that time was only 20%. So the average thing that somebody buys costs 20% more at the end of that decade. But medical care, medical equipment, all the medical things overall cost 125% more. And again, this is very important, and it's something that we'll talk about more as we go along here. So I kind of just wanted to point out where some of the spending is going. For health consumption expenditures, you can see from this chart, this is 2017. Out of pocket, we paid $365 $365 billion of the $3.3 trillion. And then the health insurance paid the majority of it, the $2.6 trillion out of the $3.3. And the perhaps more interesting thing is, of that $2.6 trillion, private health insurance paid $1.183 trillion, Medicare paid $705 billion, and Medicaid $581 billion. So if you combine Medicare and Medicaid and a few other programs, you get the amount that the federal and state governments paid. So you can see that roughly a little less than half of what we're paying is coming from private health insurance, a little more than half is coming from governments. So I think it's just interesting to know that when people start talking about the federal government paying for this stuff, the federal government's already paying for more than half of what we spend. So I'm just trying to set some perspective there. And so why do we spend so much more than other countries on healthcare? And this came from the New York Times. And it says, studies point to a simple reason. It's the prices, not to the amount of care. So we don't use any more care than other countries do per person, but we just pay a whole heck of a lot higher prices. And they made the statement here, lowering prices would upset a lot of people in the health industry. So if you look at the people that are collecting a lot of this money, if they had to lower their prices, they wouldn't be very happy. But it's important to understand that the reason we're paying more is just because prices are higher here than they are in price. So a couple other things. There's at least 20,000, I've seen studies up to 40,000 Americans die each year because they can't afford the medical care that save their lives. So that's somewhere between 5 and 10 Coloradans that will die this week because they can't afford medical care, and next week because they can't afford medical care, and so on. This obviously doesn't happen in other countries. Medical care deaths is the #1 reason for personal bankruptcy, and there are somewhere between 600,000 and 700,000 medical bankruptcies every year in the U.S. So that somebody is losing everything that they have because they got sick or they got injured. Medical insurance through employer plans limits employment opportunities. So particularly for younger people that are looking for a job, if they get a job with somebody that has an employer health insurance plan, and that's not really where they need to be, it's not where they can make the most money, it's not where they can make the best contribution, but they look at this other business over here that doesn't have medical insurance, and they say, I can't move there. I can't move to that company because they don't offer health insurance. Or they're charging the employees a very high percentage of the plan or something. So it really limits employment opportunities for people. And I think it also limits some business opportunities where companies can't afford to have a plan for their employees. It makes it difficult to get good people. And of course, we pay twice as much or more for the same drugs. In many cases, substantially more than twice as much. If you heard the reports lately about insulin prices going up in the U.S., they've gone up 700 or 800% here in the last 5 years. And that's not true anywhere else. And those are not new drugs. Insulin's been around a long time. So, again, we're paying twice as much and more for the same drugs. So you might think if we spend twice as much as other countries on health and medical care, we might have some of the best outcomes, right? And you could make the case, maybe, if we have a lot better outcomes in these other countries, maybe it's worth spending twice as much. But, dead last again. So this is a report that the Commonwealth Fund does every few years. They look at healthcare outcomes. And this particular slide was from 2014. I have a newer slide that's in the next section. But the quote at the bottom, I think, is the important thing. Among the 11 nations studied in this report, Australia, Canada, France, Germany, the Netherlands, New Zealand, Norway, Sweden, Switzerland, the United Kingdom, and the United States, the U.S. ranks last, as it did in the 2010, 2007, 2006, and 2004 editions, the report reads. So not only are we paying these incredibly high prices, but we're getting lousy outcomes compared to these other countries. And so just in case you think, well, maybe we've gotten better in the last few years, here's the 2017 report. And out of the 11 countries, overall ranking for the U.S. is 11. And we rank pretty close to 11 in most of the categories. Somehow or other, the French actually are worse at administrative efficiencies than we are. We're number 10 in that particular category. But healthcare outcomes, which I think is really the key, how are we doing in terms of people getting good healthcare and recovering and being able to live a normal life, we're still last. So there's an issue here that you should be aware of, and I think this slide really points it out. I'm going to come out here and kind of point at things. This brown area down here at the bottom of this graph, and we're running from 1970 to 2009, that's the increase in physicians over that period of time. And it pretty much tracks the population increase. This green area is the increase in administrators, which you can see is way, way, way bigger, right? And why is that? And if you come back here, some of you probably remember, it used to be when you went to the doctor and you had insurance, you had to take a form from the doctor and send it to the insurance people to get a reimbursement. They'd send something back. Well, that really wasn't working very well, so at some point the medical providers took over filing those claims for you. So you don't really do that anymore. The provider files the claim against the insurance. And what does it take in order to do that? It takes people, right? You have to have people on staff that are doing that. And when somebody comes in and needs something, the provider has to check with the insurance company, see, are you going to cover this? And then the people that do this will tell you they often have to argue with the insurance company to say, hey, this patient really needs this, and you need to pay for it. And they may have to get the doctor to send a letter, or there's just all kinds of stuff that goes on. So that's why we need all these administrators. And every provider that files claims against an insurance company has to have people on staff to do that. And I've had physicians tell me that up to 35% of their practice income is just spent on administration, just dealing with insurance companies. Okay, so there's three key issues I want you to take away from what we've done so far. Number one is that our healthcare prices and therefore healthcare spending are much too high. They're already way too high. And the second issue is that the medical inflation rate is several times higher than the overall inflation rate. So not only are our prices and our spending way too high, but they're going up very fast, getting more and more expensive. And the third issue is there's very little in our current system that can hold down prices and price increases. And I would contend, and I'm not going to give you a long explanation of why I think this, but I would contend that most providers and insurance companies and hospitals make more money when prices are higher than they do when prices are lower. So the incentive for many of these people is to just push the prices up. Now, there's clearly a limit as to how far that can go, but there's a lot of companies today are only concerned about short-term profits. Now, I've worked in for one of those kinds of companies, and that's what they look at. What's the stock price? Because all the executives' bonuses are based on the stock price, and the stock price is based on what's the profit going to be over the next few years. Not is this going to be a viable business 10 years from now. Okay, so remember those three things: prices are high. Prices are going up very fast, and there's very little that's trying to hold them down. So one of the things that I sort of question is, how the heck did healthcare become a liberal issue? And I put liberal in quotes, because everybody needs healthcare at times, right? It doesn't matter. You might be the most conservative person in the world. You're going to need healthcare sometime. You might be the most liberal person in the world. You're going to need healthcare. You might be right smack dab in the middle. So everybody needs healthcare. And it used to be more of a bipartisan issue. So the Canadian Medicare system, their single-payer system, which they call Medicare, was created by Tommy Douglas, who was a conservative prime minister of Saskatchewan province. He didn't do it because he believed that healthcare was a human right. He did it because he looked at the businesses in Saskatchewan and he said, these businesses are really hurting when somebody gets sick and can't get medical care, because that's a skilled worker who is now not available to work. And so he said, it would be much better if we had a system where people could get medical care when they get sick or injured and get back on the job. And you may have heard a couple months ago, somebody in Canada did a thing where they asked people, who's your favorite Canadian hero of all time? And you know who was number one? Tommy Douglas. It wasn't a hockey player. It wasn't a politician recently. I mean, his stuff happened back in the 50s, I think. But he was the number one person because the Canadians appreciate so much that he put in a universal health care system. And of course, the Massachusetts health care system was created by Mitt Romney when he was governor, and he's a Republican. So somehow we've got skewed to where people think of health care as a liberal issue, and to me, again, it's an issue that affects all of us. So just so we have an idea here, and as we lead into Medicare for all, and why we think that's one way that we should clearly look at it and potentially go. There's three general ways in which other developed countries pay for health care. One is government-controlled health care. So in the United Kingdom, Italy, Spain, Hong Kong, all the doctors are employees of the government. The nurses are employees of the government. All the hospitals, the equipment, everything belongs to the government, and the government runs the system. Okay, that's one way of doing it. And you might, if you remember the London Olympics opening ceremony from 2012, what was one of the things that they paid tribute to? The National Health Service. Anybody remember that opening ceremony? National Health Service, a big deal. And most people in the UK really appreciate the fact that, again, they can get health care when they need it, and they don't go broke doing it. The second way is mandated and regulated private insurance. And so rather than just having this kind of free-for-all like we have, where the insurance companies do whatever the heck they're going to do, they say, okay, insurance companies, this is what you can do, this is how much you can charge, and everybody's required to buy insurance in those countries. And I'm told in Germany, if for some reason you lose your job, the government pays your premium, while you're unemployed until you get employed again. So it's a combination of the government and private insurance in those countries. And then the third way that people do it is single payer. And that's, for example, Canada, Australia, Taiwan, South Korea. And what that means is that the providers, the doctors, the clinics, the hospitals, so those are all private entities. And they provide health care to people. And then they submit a claim to the government. And the government pays for that. So it's called single payer because there's only one entity that's actually paying for health care, and that's the government. So those are the three: government-controlled health care, mandated regulated private insurance, and single payer. So when we talk about Medicare for all, which is a single payer type system, it gets a little bit confusing because it includes the word Medicare. And there's already a Medicare system, and some of us are already on it, and we know how it works. But what we're really asking for, and I think what the two bills that are in the Congress fit, is what we call a national improved Medicare for all system. So it's national because it's a program of the United States federal government. So we're not talking about a state by state by state kind of system. It's something that would go across the entire country, one system. Improved is there because it's more comprehensive benefits than current Medicare, and I'll show you those in a minute. It's Medicare because it's an expansion or an extension of that existing Medicare system. And all just means it covers everybody. Everybody's health care needs are covered. So we're going to talk about National Improved Medicare for All, or NEMA. We'll shorten it up so I don't have to say that over and over again. And let's just talk a little bit about the existing Medicare system. So Medicare currently is supported primarily by payroll taxes. When people reach age 65, Medicare pays for approximately 80% of their incurred medical expenses. After they pay their deductible for 2019 is $185. So, compare that to the $5,000 and $6,000 deductibles on private plans. And the Medicare premium is $135.50 a month for 2019. that may be higher for some high income earners. So you actually, even after you go on Medicare, you're paying that $135.50 a month. And they will gladly take it out of your Social Security check. And so, you don't even see it really, for most people. So there are currently two bills in Congress that I would classify as national approved Medicare for all. The first one is the Medicare for All Act of 2019, which it says just introduced, actually been several months now. It was introduced in the House of Representatives by Pamela Jayapal, who was the lady that I pointed to in that one video. And then, of course, the Medicare for All Act was introduced by Senator Bernie Sanders in the Senate in 2019 after the bill that he introduced in 2017. But there is a big, and there's some differences between the two bills, but they're fairly similar. Probably the biggest difference is that the Jayapal bill takes 2 years from the time it starts until everybody's covered. And the Sanders bill takes 4 years from the time it starts until everybody's covered. And there are, again, some smaller differences in there, but they're pretty similar. So let's look at NEMA versus current Medicare. Current Medicare covers people 65 and over, right? NEMA covers everybody. Current Medicare is supported mostly by payroll taxes. It's not exactly clear what the revenue mechanism is under the new bills, but it's likely to be similar. Current Medicare has that monthly premium we talked about. Under NEMA, there is no monthly premium. The idea there being that everybody can afford to be covered. There's people that are really poor and they can't afford that $135.50 a month. We're just not going to charge it because that's a hindrance to people being able to get their medical care. Current Medicare covers 80% of charges after the deductible, and NEMA would cover 100% of charges with no deductible. Current Medicare is optional. You don't have to sign up for it. NEMA would be required. Everybody would be in the system. For current Medicare, not all providers participate. Some doctors, hospitals, and so on don't like to take Medicare because the reimbursement rates are lower. Under NEMA, almost all providers participate because there's no place else to go for payment. There might, I mean, we talked about this, there might be some Hollywood dermatologist who only takes cash to do facelifts and tummy tucks and that kind of stuff. Movie stars go there to pay cash and rich people. But in general, you have virtually everybody in the network. Under current Medicare, there's no dental, vision, or hearing aid benefits. And under NEMA, those would be provided, more comprehensive benefits. And those of you who have Part D pharmaceutical coverage under current Medicare, it's a mess. And under NEMA, we have comprehensive drug coverage. So the next question is, how much would NEMA cost? And I've got $32 trillion question mark there. So I want to play a little video. I have to apologize for my video editing skills. This is a little bit rough. If I could have, if I'd been better at it and found a way to do it faster, I would include even a few more little clips here. But let's just watch the ones that I picked.
It's frightening. Estimates, as you mentioned, up to $32 trillion. Almost.
Just say to you, Medicare for All is expected to cost $32 trillion over 10.
Now, we know that Medicare for All represents a $32 trillion expenditure to the federal budget.
So these were during hearings in the House of Representatives. People talking about $32 trillion. And like I say, if I'd been better at video editing, I could have put 10 more on there, somebody saying $32 trillion. So the question is, is that what it is, $32 trillion? This is where we start to get into what's this actually going to cost. So $32 trillion is over 10 years. It can't be $32 trillion a year because we didn't produce that much. The whole economy is about $21 trillion, I think, right now. So $32 trillion over 10 years, that's $3.2 trillion a year. Just take 32 divided by 10. We spent $3.65 trillion last year. Remember that from the earlier slide? So yeah, we get to save $450 billion in the first year, right? Well, they're all wrong. And I couldn't find a good frown emoji to put in there. PowerPoint's not very frown, but I mean, that's just not right. That's not even close. So where did the $32 trillion number come from? Well, it came from a study done by the Mercatus Institute. It was done by Dr. Charles Playhouse, who's the man in the middle of the picture here. And that's not what he said. He didn't say that it was going to cost $32 trillion over the next decade. What he said was, it's going to cost, the federal government is going to spend an additional $32 trillion over the next decade, over and above what it's already spending. Okay? Just for context, the Mercatus Institute is a conservative think tank. So you might expect that they are not necessarily thrilled about the idea of a big new government program, and maybe they come up with a higher number. Maybe not. I'll give you a number from a liberal think tank that's different later on. But just, again, to put that in perspective, that's the highest number that we've seen, is current spending plus 32 trillion. And then actually, after a while, they said, well, it might be 38 trillion more. Okay? Now, if you take those numbers and try and figure out what's the current federal spending and add them all together, it's a difficult thing to do. But fortunately for us, Dr. Playhouse stated in one of these hearings what he thought the total spend would be. So that's what we're going to play here.
Total federal spending on Medicare for All over the first 10 years would be somewhere between $54.6 trillion and $60.7 trillion.
Yikes. Between 54.6 trillion and 60.7 trillion. Those are big numbers, right? That sounds terrible. That comes out to between 5.46 trillion and 6.7 trillion, 0.7 trillion per year, and we only spent 3.65 trillion last year. But again, that's not the whole story. Okay. All of that 32 trillion stuff that people were saying in the House hearing was designed to scare people. Okay, that's why they kept saying 32 trillion. And to me, there's two things. Either one, they were just they understand what's going on and they're trying to scare people, or two, those congressmen don't understand what's going on. You want to guess which one I think it is? It's a combination of the two. They really are trying to scare people, and they really don't understand what's going on. There were a number of them that said 32 trillion per year. So, why is the amount in the Mercatus study so high? Number one, Dr. Playhouse is assuming an increase in total health care spending of approximately 6% per year. So he's got healthcare spending going up 6% over the previous year for 10 years. Okay? Now, is that a good number? It probably is. It's probably a good number. What did we say the inflation rate, medical inflation rate is? Remember that slide where we showed the medical inflation rate? The last few years, it's been over 6%. And of course, there's a little bit of population growth. I looked it up, we're growing at about 0.7, 0.8% per year in population. So there's more people, therefore more health care. So that number's probably not a problem. And then the second thing that made it high was the decade that Dr. Playhouse is analyzing starts in 2022. Now, why did he pick that year? He picked that year because he was analyzing the Bernie Sanders bill from 2017 and saying, it won't start covering everybody for 4 years, so I'll start at 2022. That's when the big spending would start out, right? And so he goes from 2022 to 2031. But we know that healthcare spending is going up 6% a year, so that means in that 4 years before he gets started, how much is it going to go up? It's going to go up a little over 24% just in those 4 years before his study even starts, right? So I'm guessing that if you use the assumptions that he used about how much additional care there would be and how much savings there would be, those numbers are probably not too far off. But the real key is, how much are we going to spend if we keep with the current system? Okay, you can't compare 10 years worth of spending going up 6% every year, starting in 22 with what we spent last year. That's not a valid comparison. So what I did was, I took Dr. Playhouse's assumptions. I don't know if you can see these or not. But I started with a $3.65 trillion that we spent in 2018. And I bumped it up 6% a year until we got to 2031. You want to see a scary number? $7.79 trillion in 2031 if we don't do anything different than what we're doing now, and if it grows at 6% a year. And that's simple math. I mean, I didn't make any sort of assumptions here other than that 6%. Okay? So then the question would be, if we take the time period that Dr. Playhouse had from 2022 to 2031 and added all these numbers together, what would it come to? So this shows the low estimate from the Mercatus study at 54.6 trillion, the high estimate from the Mercatus study at 60.7 trillion, and 60.74 trillion that we spend if we don't do anything different than what we're doing now. And I think that's very interesting. If we don't do anything different, we're going to spend the same amount or more that Medicare for all would cost. And we're still going to have the crappy system that we have now instead of something that covers everybody. Now, I don't claim to be an economist. I just ran those numbers. And again, I took his words as to how much he thought it was going to cost. And I took what we're spending now and went up 6% each year. And that's what you come up with. So as the pharmacy companies, the insurance companies, the big for-profit hospital chains try to scare us by talking about how much Medicare for all will cost, we got to compare it to what it's going to cost if we don't do anything different than what we're doing now, right? Does that make sense? Okay, so there was another study done that examined the cost of National Group Medicare for All. And I want you to hear a little bit of video on this one. And this guy is not the one who did the study. I'll show you who did the study, but he's the moderator.
And specifically, your study shows that, and that was Galvani's review, I would add, specifically, your study shows that Senator Sanders' Medicare for All Act can provide universal coverage of every resident in the United States as the system as a whole absorbs a 12% increase in demand for health services. More people getting coverage are going to use more care, but it still realizes a 19.2% in potential cost savings overall. That and the cost of prescription drugs under your approach would be lowered by 40%.
Okay, you hear what he said? A 12% increase in usage, because you've got people coming in that they weren't getting medical care before. So there's estimated to be a 12% increase in usage to cover those people and to cover some things that weren't covered before. And yet, this study is showing a 19.2% savings versus the current system. So these are the people that did this study. You probably don't know the names, I don't know the names, but it's the Political Economy Research Institute at the University of Massachusetts, Amherst. And Amherst is actually quite well known for economists, healthcare economists, people who look at our medical system and project what's going on. Now, the other thing that I found interesting about this study is there's some financing assumptions. You don't see that very much. But their savings was, and this was a little bit confusing, but they still would have businesses paying taxes that are 8% less than what they're paying now for employee insurance. And so that generates some revenue. They're suggesting a sales tax on non-necessities, a national sales tax. 3.75%, that generates $196 billion. A net worth tax of 0.38%. So you may have heard Elizabeth Warren talk about a net worth tax. So you take what somebody's got in assets minus their liabilities, and then they pay a small percentage of that as a tax. In this case, 0.38%, less than a third of a percent of whatever their net worth is. Again, these are sort of general ideas that are being thrown out there. Taxing long-term capital gains is ordinary income. So long-term capital gains, if you buy stock and you hold it for more than a year, then you sell it, you pay a capital gains tax on the profit, 15%. If you're a wealthy individual, your income tax rate on earned income is much higher than that. So the idea is to tax those long-term capital gains as ordinary income, and that would generate some revenue. So I just throw these out there because you can see people are thinking about different ways that you might raise the money to pay for this. And there are other experts that show even more savings than that. Now the key point here, though, what I think is the most important point on this, is that Medicare can hold down medical inflation by controlling reimbursement amounts. Okay, what other way of holding down that medical inflation is there? And I can't think of any way of doing it. I mean, obviously the government could pass a law saying we can't raise prices. If any of you are old enough to remember back when Nixon was in office, they put in price controls. They literally said you can't raise your prices. Whatever your prices are now, they have to stay there. And those laws were in effect, I think, for a year or 2 years, whatever it was. So the government could do that. That's kind of a blunt force sort of approach. But the good thing here is that Medicare sets reimbursement rates for providers. And so Medicare can say at that point, you can't raise your prices 6%. We're not going to increase our reimbursement rates 6% every year just because you private insurance company want to make a lot more money, or you pharmaceutical company want to make a lot more money. And of course, Medicare can also negotiate drug prices if the federal government allows them to do that. Right now, there's a federal law that says Medicare can't negotiate drug prices. That was part of that Part D, Medicare Part D drug coverage that came in. Medicare can't negotiate drug prices. Every other country, every other developed country in the world negotiates drug prices, but we don't. So the other big thing I see about Medicare for All is that we can hold down that inflation. And we can even reduce reimbursements over a period of time if that's the direction we decide we want to go. There's pros and cons to doing that. So how would we pay for NEMA? We saw a couple of things from that other study where they had some suggestions. These are some ones that I think are likely. Payroll taxes on employers and employees in place of the medical insurance premiums that they're paying now. Income taxes for non-employee income. If you have non-employee income, you don't pay Social Security and Medicare taxes on that. It's only employee payroll income that you have to pay those taxes on. So there's a lot of people that get substantial amounts of money, but they're not employees of somebody, and they don't pay those taxes. So it would make sense if they're going to get medical care from the government that they should pay the same kind of taxes that people that are working for a paycheck are paying. General federal revenue sources, obviously there could be income tax increases or cancellation of the last income tax cut, all those sorts of things that the federal government could do. I threw this up here just as an attempt to put a little bit of humor in. You can see that this person, you probably can't see it, but this person works for insurance companies, and he's a lobbyist, and he says he's giving a bunch of money to somebody in Congress, and he says, in exchange, you say we can't afford health reform. And lobbying is a big deal. So how would costs be reduced under a Medicare policy? We've already said there's going to be more expenses. We're going to have to pay for insurance for more people, right? So we have to have some offsetting cost savings in order to do that. So the first one is elimination of most administrative expenses for providers. Let me back there. That is the most important one. That's that green area on that chart that we showed. So if we can cut administrative expenses for a doctor's office from 35% to 5 or 10%, there's a huge savings there. Second is the elimination of medical insurance company profits and administrative expenses. So all these medical insurance companies also have large administrative expenses and large profits, which don't do anything to pay for everybody's health care. Prevention programs for all. Where's the most effective place to put your money? It's in prevention. There's all kinds of stories I can tell you about that. I don't want to drag this out, but it's much more effective to put your money in prevention for people, keep them from getting real sick and then having to go through expensive stuff later on. Reduce drug costs, we talked about that. The VA pays 43% less overall, I think it's 43% roughly, than we do, because they actually are allowed to negotiate drug prices. Elimination of unnecessary services. Again, this is the kind of thing where somebody may be going to one doctor and getting a service, going to another doctor and getting a similar service, and if we have the right kind of electronic medical records and one entity paying for all that, I think we can eliminate a lot of that stuff. Increased efficiency, we talked about that. Medicare says reimbursement rates going forward, again, keeping that 6% medical inflation rate down. And I think there's some reduction in fraud because, again, you just have one entity that's paying for everything. So then you start to hear the term socialized medicine. Is this socialized medicine? And my contention would be that socialized medicine is generally defined as a system where the government controls all the health care. So you can make the case that what they have in the United Kingdom, Britain, and some of the other places is socialized medicine. It's the government running the entire medical system. But services under Medicare are delivered by private entities. So it's private doctors, private hospitals, private clinics, and Medicare just pays the bills. So the treatment that you get under Medicare for all or under current Medicare is determined by your doctor, not by the government. The government doesn't have people that the doctor has to go to and say, can I treat this person for this? The doctors just do it. So your doctor decides what services you receive. And again, I'm trying to not get too partisan, but here's somebody sitting there and the doctor says health reform. And this person says socialism. And the doctor says your reflexes are good. Now the people that are doing that are the people that are making a lot of money off the system right now, right? Health insurance companies, pharmaceutical companies, for-profit hospital chains. They don't want this to change. They don't want this process to go away. The other thing that I started hearing, I got kind of unhappy at hearing people saying, do you support government-run medicine? Really referring to Medicare for all. It's not government-run medicine, it's government-paid medicine. But again, there's people out there that want to confuse people and make it look like we're going to get something really bad because. So, what's the current status of National Approved Medicare for All? Public support is definitely growing. 70% approved in the latest Reuters poll, including a majority of Republicans. This is way up from approval rates of a few years ago. But it's unlikely to be implemented at the current time with the current administration. That's just a fact. President Trump has said he doesn't want to address health care until after the 2020 election. And then, who knows what might come out at that point. But it's definitely unlikely to be implemented at the current time. And the reason is that the politicians are going to have to get more pressure from their constituents than from the lobbyists before they're going to do anything. What about tweaking Obamacare instead of going to Medicare for all? This is something that you hear people talking about. There's a number of the Democratic candidates for president that are saying we need to keep Obamacare and we need to tweak it. I think there's a lack of political consensus for that, particularly on the Republican side where they've attacked Obamacare just over and over and over, trying to repeal it and so on. So I don't see how you would ever get a bipartisan majority to pass much in the way of tweaks for Obamacare. Whatever you do would probably require massive federal government subsidies. That's basically what Obamacare is, right? It pays subsidies for people to get insurance. So if you want to cover a lot more people, you have to subsidize a lot more money. Is that a good thing? And if you're going to have massive government subsidies, wouldn't it make more sense just to cover everybody under Medicare for all? It does little to reduce total spending and spending growth. And that's, I think, proven by those charts we looked at. We're spending twice as much as other countries per person, and we're going up much faster. So Obamacare has not been able to control that. Well, what about a buy-in program for Medicare? So there's, again, a number of people that are suggesting that we ought to allow people to buy into Medicare. The problem, of course, is who gets to buy in? who pays. I mean, you can't just let people go on Medicare and start paying $135.50 a month where they've been paying a couple $1,000s, for insurance. Somebody's got to pay for that, right? So it's not clear at all who would pay or how much. Would there be deductibles and co-pays? Well, you have those in current Medicare. We don't know. If people were buying in, probably they'd still have to pay a premium and have deductibles and co-pays. And of course, some people still will be able to afford it. And it's the people in the middle that kind of get caught. The people at the bottom can get on Medicare. The people at the top, particularly a lot of them have employer plans and so on. They're not too unreasonable. So it's people in the middle that really get hit hard. So I'm skeptical about buying a program for Medicare. So what about a public option? Here's another thing that people talk about. What's a public option? It's basically an insurance program that's run by the government. In just simple terms, that's what it is. It's insurance that's run by the government. And down here at the bottom, if you can see it, oops, wrong button. Most of the estimates on what you can save by running an insurance program through the government come in about 7 or 8%. So if the state of Colorado were to establish an insurance program that's run by the state, or the U.S. were to establish an insurance program that's run by the government, the maximum you can save on that's probably 7 or 8%. And again, our inflation rate is 6% per year, so that savings will be gone in a year and a half. And of course, an insurance program has the same kinds of problems that we have now. This actually comes from Physicians for a National Health Program, which is an organization of physicians who are really lobbying hard to get a Medicare for all type system. So, would it guarantee coverage for everybody? No. Single payer would, but public option wouldn't. Does it eliminate co-pays and deductibles? Again, Medicare for all does, public option doesn't. Does it cover all necessary care? No. Does it ensure choice of doctors? No. Does it control costs without compromising access to care? Again, no. These are their opinions about this, but I think it's pretty reasonable that that's the case. So again, public option would save us some money. We're not having a public option, but it doesn't really solve the problem. So there are still some issues to be solved if we were to decide to go to a Medicare for all type system. The first one is the displacement of jobs in the private health insurance industry. And really what I'm talking about there is both the insurance industry and the people that are the administrators for the providers right now. So there's going to be a bunch of people who lose their jobs. So we need to figure out what are we going to do for those people. Are we going to support them with extended unemployment benefits? Are we going to give them retraining? I still contend that most of the people that are involved in this side of it, that are doing the administration on the insurance, have got to be pretty sharp people or they wouldn't even be able to do it because it's complicated. And they won't have such a big problem finding the jobs. But there is, clearly some displacement there we have to think about. Reimbursement rates for providers. And this is where they start talking about if we start reimbursing all the providers at Medicare rates, is it going to put people out of business? The people at Mercy Hospital area will tell you if they have to take Medicare rates for everybody, they'll go broke. I don't know if that's true or not, but that's what they say. So we got to consider that. It's a big problem for rural hospitals. It's tough to run a rural hospital in the best of times because you just don't have the number of patients coming in. You're serving large areas and so on. So that's tough. So we got to think about, what are we going to do about that? And one of the things that's been thrown out there is block grants for hospitals, for nonprofit hospitals. So Mercy would get X number of dollars based on the number of patients that they see in a year and the types of procedures that they have to do. And then it would get updated probably every quarter. So if there were more people moving into Durango than expected, and Mercy's got to cover more people, then we adjust that upward. So there are some ways to do that, but it's something that still has to be worked out. We can certainly expect strong resistance from the companies making big profits from the current system. And this is an interesting thing that happened here in the last year or so. Leading pharmaceutical insurance and hospital lobbyists formed the Partnership for America's Healthcare Future. That sounds pretty good, right? Partnership for America's Healthcare Future. It's an ad hoc alliance of private health interests to curb support for expanding Medicare. So we've got to figure a way around that. And there's certainly a lack of understanding of the National Approved Medicare for All among the general public. So you may have heard them talking about, if you ask people, do you support Medicare for all, you get a pretty good response to that. If you say, do you support Medicare for all if you're going to lose your private health insurance benefits? Well, support for that drops way down. I don't want to lose something, right? I'm all in favor of getting something good, but I don't want to lose what I already have. But the point is, you don't need that anymore. Why would you want to pay for private health insurance if everything's covered through this national program where you're already paying taxes? So it's a question of how you phrase the question. You know, do you scare people by saying, well, you know, would you still support it if you lose something? You're not really going to lose anything, but that's the way the question gets asked. So again, a big part of what Healthcare Durango is trying to do is to inform people about what's really going on so that people can make intelligent, informed decisions. So what can you do? We're almost to the end here. You can become informed. Hopefully we've helped you with that today. And you can tell your friends and acquaintances what's going on. So if somebody comes to you and says, how are we going to afford Medicare for all? You say, we're going to take the money that we're already spending, we're going to give it to the government in taxes, and then they're going to pay for all the bills, and it's not going to cost us any more than what we're spending now. And probably cost us less. So you can say those kinds of things. Contact your elected representatives. Remember what we said about how nothing's going to change until our elected representatives get more pressure from us than they get from the lobbyists. And they're getting a ton of pressure from the lobbyists. And obviously vote for candidates who support real Medicare for all if you think that's a good thing. So, that's the presentation. What questions does anybody have?
I have been to another one of these, and you mentioned before that Medicare currently has about a 3% overhead, just as a perspective to show how can you manage so much better.
So, a lot of people, I hear this thing that the government can't do anything efficiently. Well, the administrative expenses for Medicare are 2 to 3%. So that means that 97 or 98 cents of every dollar that they spend goes to health care for somebody. For the insurance companies, they spend roughly 20% for administration and profit. Means 80 cents out of every dollar they spend goes to actually pay for somebody's health care. So which one of those is more efficient? It seems pretty obvious to me that the government-run Medicare system is much more efficient than the private insurance companies. And of course, the private insurance companies didn't even used to spend that much. The Obamacare law required them to spend at least 80 cents out of every dollar on actually providing health care. So I think it's pretty clear that the government can, in fact, do this sort of thing efficiently.
Another point that I don't remember you covering this, but was this the disparity of costs all over the country? That you go here, it costs this, you go here, it costs this, and it's just incredible. I think Medicare for all would even that out.
Sure. And a lot of it's just whatever they think they can charge. Mercy Hospital is actually one of the highest charging facilities in the state. Because I've gotten involved with the Durango Healthcare Alliance group that's trying to start up. And one of the things that they're looking at is what do different hospitals charge for things. And Mercy is like second or something in the whole state in terms of the highest rates. So, I had hernia surgery last year. My bill from them was $42,000. I was there for 4 hours? $42,000. Medicare paid was $6,000. Since I'm on Medicare. So you've got all sorts of non-transparent pricing too. Yes?
A question I have about what hasn't been covered or mentioned has been liability expense to medical providers. How would that be handled with Medicare?
That's a good question. Generally in other countries, malpractice insurance is very cheap if they have it at all. Nobody sues doctors in these other countries. Okay, and I don't think that Medicare can do much about that. I think it's our laws that allow people to sue medical providers that drive that up. And I know, I've seen any number of situations where an insurance company says, it's not worth our while to fight this claim. Somebody's sued us for X number of dollars, and it'll cost us more than that to defend it, so we're just going to pay it. We don't admit liability, we're just going to pay it. And so, our malpractice system fits right into that, where somebody has a bad outcome. Is it really the doctor's fault? I mean, doctors are going to make mistakes too, right? They're just people. They're going to make a mistake every once in a while. Do we really want a system where somebody can then sue them and make money off of that mistake? I don't know. But again, I don't think Medicare for all would take care of that. I think we would need some changes in other laws.
Australia has a program where a physician's liability is limited to a reasonable amount. The government takes over after that.
Sure.
If somebody sues for $10 million, might have to pay, I don't know how many thousand, but the government then intends it after that.
Sure. I think malpractice, it makes sense. If somebody truly is not practicing medicine in a proper way, they probably ought to get their medical license suspended rather than being sued. But there's no question. But again, a lot of the things that people end up suing for are things the doctor couldn't control in any case. Any other questions, comments? We'd really like to thank everybody for coming. Again, the website is healthcaredurango.com. I probably should have made it .org, but it's .com. And we will be putting all sorts of good information, I think, up there, little video snippets and links to other places. Hopefully you'll get involved and, again, tell other people about this. Spread the word. You can write letters to the editor and get them published in the paper, that sort of thing, saying,